Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News with our on-site coverage of the ASH annual meeting. And it's my absolute and utter pleasure to be joined by Dr. Jain, a world-renowned CLL expert from MD Anderson, to talk about the CLL-17 study. Welcome, Dr. Jain.
Glad to be here.
All right, so plenary sessions, CLL-17, really important study. But it took a lot of people. It took a lot of effort.
Right.
And some of the cool stories about these studies, like I'll use the Ratify trials example. It's a consortium of people working hard over many years to get these trials done. Can you tell me about like the group of folks who pulled together to do this study?
No, I think this is a study led by the German CLL study group, and they had this consortium in Europe with multiple other centers and multiple other countries. And I must say they do a fantastic job in terms of accruing patients to the trial, designing this fantastic, almost 900 patient, 1,000 patient trial, accruing these trials, and really able to answer very important questions in a very relatively rapid fashion. And so this is just a remarkable that we have the German CLL study group and all the European countries, these cooperative groups, kind of coming together, working together to be able to answer these very important questions, which I think I'm happy that they're able to do that, and that's great for the field.
I mean, it is really amazing answering those questions maybe industry won't answer that we all have. And it provides an important function and plays an important role in what we're doing.
Right.
All right, so a debate. Continuous, discontinuous, intermittent, whatever you want to say. Can you set up the debate for us between these two strategies?
Yes, historically, ibrutinib was approved for CLL back in 2014. And it was a continuous therapy, right? So that was the first kind of target therapy major player in the field. And then a few years later came obinutuzumab, where the argument was you can just use 1 year of 2 drugs and it'll be fine. And then more recently came this ibrutinib venetoclax and acalabrutinib venetoclax, where also it's like you can do just 1 year of therapy. So the big debate has been, should I use continuous, one drug continuous like a BTK inhibitor, or should I use a doublet or maybe a triplet in a time-limited fashion? When the study was designed, several years ago, ibrutinib was the main player in the market. And the 3 basic regimens, which were the most popular at that time, were continuous ibrutinib with venetoclax for 1 year, or ven plus obinutuzumab for 1 year. So the study said, okay, let's ask this question, this big randomized phase 3 study, let's see which arm wins. So like a perfectly designed study, and with large number of patients to answer that question. I guess the main question was, do we need to have, they wanted to see if the time-limited therapy will be non-inferior to continuous therapy, and they met the primary endpoint that the time-limited was non-inferior. And they had a 3-year follow-up data which they presented at the plenary session, which looks pretty similar across the groups. So they kind of, and I would say in the big scheme of things, it is the practice we have adopted. So I will say this is a practice confirming, practice affirming study, in which we now, like many of us, have been doing time-limited approaches more and more. But I would say that obviously that's not the universally adopted strategy. So this study will maybe ask clinicians to think about it if they're using continuous BTK therapy, that hey, you can do time-limited, and at least at 3-year mark it works the same. What will happen 5 years down the line, or 2 more years of this study follow-up, is very important to see. While the groups are starting to separate a bit, I guess we'll see in a couple of years how that plays out. But overall, I think this study, kind of really is concurrent with what we think about these strategies. And this is really the first study to kind of help us, delineate that in a randomized fashion, to say.
I think that's fact. I don't want to belittle the fact that practice for confirming studies are important, right? So if you look at like guidelines, so when you write a new guideline, it takes approximately 8 years for those guidelines to be implemented, right? So anything you could do to kind of pull a community together to get uniform care, I think is incredibly important. So, even though it's somewhat practice confirming, I still think it's incredibly important.
Oh yeah, absolutely.
And would you say it settles the debate, or not quite yet?
Well, I think so right now I would say there are a couple of groups, at least in the United States, or at least as a physician, I see where I still was using continuous BTK therapy. One was patients or older folks, they're 80s, you don't want to use doublets and triplets maybe. And where I think, I think continuous BTK will have a role, in my opinion. And if you look at the sub-study details of the study, patient with deletion 17p, actually that arm with ibrutinib, actually with monotherapy, still was, again, superior or numerically superior, which again is in line with what we do now, where for 17p patients, we still believe that continuous BTK is the way to go outside of clinical trials. So in some sense, everything we kind of think about how from the previous data, this study really, the data is consistent.
Yeah,
right? There's no,
that's good.
It will be different if there was totally opposite of what we have been doing or we've been thinking. So it's good to see that being confirmed in a large study, at this time.
That's fantastic. Really important data. Of course, a plenary session here at the ASH LM meeting. Right. So thank you for spending some time with me to discuss this abstract. And you can read about this abstract and all of our on-site coverage in the pages of ASH Clinical News.